this is our schematic diagram, right? For your examination, you definitely need to know the blood flow, the normal flow of the blood, and all the valves that are involved, right? So let me go through the normal flow and the valves, and then I'll give you some mnemonics to help you remember it, right? So we're going to start with the deoxygenated side first, right? So deoxygenated side comes in from all your veins, right? And why is it deoxygenated? We have different cells here, right? So here, let me draw some of the organs. It could be any organ, but let's say we have the kidney right here, we have the liver here, right? You have the muscle cells here. And what happens is during metabolism, right? They make CO2, but they need oxygen from the bloodstream that comes here, right? So oxygen gets transported to these organs for their metabolic needs, right? So mitochondria can make ATP. They produce CO2. It goes into the blood, right? The red blood cells, they pick up these byproducts, and then they move, right? So deoxygenated blood goes from the venules to the veins to your major, right? To the major systemic veins. We call this capacitance, right? Why? Because about 60% of your blood volume, right, is in your veins. So this is the major part of the body where it's stored, right? Now, inferior vena cava, superior vena cava, they're all going to drain to the right atrium, right? Through the right atrium, they're going to go through the tricuspid valve and to the right ventricle. This is still deoxygenated blood. It's going to bypass the pulmonic valve. It's going to go to the lungs, where all the CO2 that is picked up in the tissues is going to get rid of that and pick up oxygen. Now this blood is becoming oxygenated, right? And if the question asks which is the only artery that carries deoxygenated blood, you're going to say it's the pulmonary artery, right? Now, oxygenated blood that's loaded is going to make its way through the pulmonary vein. There's no valves here, right? There's 4 pulmonary veins that connect to the left atria. This is free flow of blood. They're going to bypass the bicuspid or the mitral. The way I remember mitral is it's on the mighty side, right? The left side is the big side, it's the mighty side, right? So it's going to bypass through the mitral valve, the mighty valve, to the left ventricle, come out through the aortic valve, and then the process repeats again. Make sense? What is important to know, right? 60% of the blood is usually found in the venous system. About the capillaries, arterioles, right? And the remainder of the system carries the other 40%, right? And arterioles, we call them distribution, right? So arteries, arterioles, this is the distribution side. And this is capacitance. Another way to think of it, this is the tank. Right? This side is the tank, and this side is the distribution that moves everything right around. A good mnemonic. How do I remember all the valves, right? So a good mnemonic that's PG-13 is
toilet paper, my ass.
right? So T stands for tricuspid, right? Tricuspid. P stands for pulmonic. M, right, stands for mitral. And S stands for the aortic. That's the regular order, right, of the blood flow through these valves, right? Which of these are semi-lunar valves?
The top ones are pulmonic and aortic.
Pulmonic, right? Pulmonic is the semi-lunar, and the aortic valve is the semi-lunar, right?
The way I remember it, lunar, moon on top.
Moon on top, okay. And what about these, the tricuspid and mitral? What are those?
Atrioventricular.
AV valves, right? Very good. So tricuspid is the AV valve, AV, atrioventricular valve. And the mitral here is also the AV valve.
Question, you said the bicuspid and the mitral are the same one?
Correct. The name is the same, right? Where they got the term mitral from is it was a Pope's hat, right? The cardinal's hat. It's called the mitre. And back in the day, there was a Flemish anatomist. He basically, the shape was the head looked like this, right? Let's say this was the cardinal or the pope, right? The head looked like that, and that's how the valve looks. So they call it mitral valve because of the head. They call it the mitre, right? But the bicuspid, it means two cusps, and mitral all mean the same thing, right? All mean the same thing. Now, so we went through the order of the valves, right? And this is the order you want to remember, right? This is the pneumonic fluid deployed. This is how the blood flows from the oxygenated side to the oxygenated side. And the valves that are involved, right? Semilunar valves, and we talked about the AV valves. Now, there's a few important terms that become relevant with this diagram is the following terms, right? So let me write that here, and then we will explain what they are, right? So some terms that you definitely need to know is preload. Number 2 is afterload. Another term you want to know is contractility. You also want to know what's diastolic volume, right? What is stroke volume, and what is ejection fraction, right? And there's also another law, right, that I'll add here. So will be Frank Starling's law. So let's go through all of this right now, right? So preload. Preload, the term preload means all the volume of the blood that's coming in, right, from your veins, from the capacitant side to your ventricles. And as you know, even though I subdivide this diagram into the right side and the left side of the heart, truly speaking, right, your heart ventricles fill at the same time, right? So the preload is all the blood volume that's entering into the heart, right, and it's filling it up, right, filling the ventricles up. Now, afterload, the best way I can show you is, afterload is this, right? Arterials, they have resistance, right? So we have a squeeze here. That's what keeps our blood pressure up, right? That's what is keeping you vasomotor tone, meaning if you change position from lying to sitting to standing, you're not going to pass out, right? All of you are healthy. And this is what we know as a vasomotor tone. They are constricted, right, to allow you to drive the blood pressure to your brain, right, to your coronary arteries. So this is another term for this would be systemic vascular resistance, which we see here, or peripheral vascular resistance, SVR or PVR. Now, all of this is creating a force that the ventricles must overcome in order to push the blood from the aorta. Make sense? Imagine if I squeeze down these pipes here. Do you think this has to work more or less to get the blood out?
More.
More, right? So if it's the same thing, if I took a hose
More
and I
resistance.
make it exactly more resistance, this has to pump higher in order to push the blood out. How much higher? It has to overcome the systolic blood pressure. So whatever your systolic blood pressure, right, 120 over 80, 140 over 80, 180, 200, whatever your blood pressure is, this ventricle has to overcome that pressure in order to move this blood out, right, in order to propel it forward. This force that it has to overcome is called the afterload. So the afterload is essentially your systemic vascular resistance, peripheral vascular resistance, and everything that's causing the contraction of these arteries and arterioles, and all this force that the left ventricle has to overcome to push the blood forward, right? Yeah, you will have the afterload on the right side, but we usually don't talk about the right side. Why? Because this pumps into the pulmonic circuit. The pressures are here much, much lower than on the left side. So usually when we refer to the afterload, we're referring to, right, the pressures the left ventricle has to overcome. You have a question?
Yeah, I thought that preload was the atrium filling.
Atria is filling. So not necessarily the atria is filling, because think about this, right? Everything is determined based on pressures. So look, the moment the pressure here, right, in the right ventricle, right? Well, let me ask you this: what do you suppose the pressures are here? if we said in the aorta, let's say a normal person maybe 120/80, what do you think the pressure is here?
Lower.
Very low. It's like 2 to 5, right? 2 to 5. And when the pressure is so low, right, the ventricles start initially to passively fill because the tricuspid valve opens and it fills. The atria only contributes about 25% for the atrial kick, right? When you have that atrial depolarization, it will contract and it will squeeze the remainder 25%, right, to fill, right? But when we talk about the preload is essentially all the blood that's coming in to both your right and left heart, right, during the filling.
Okay,
Right.
so everything is being filled at the same time?
The right and the left ventricles are being filled, right, up to a point, as long as this pressure does not exceed, right, this pressure here is lower than this. The moment this pressure exceeds this pressure, the valves close.
Right.
Yeah.
Kind of like when you breathe. That's a good pressure.
Yeah, that's why when you breathe, right, so she has a good question, right? What happens when you have negative pressure breathing, right? I take a breath in, right?
The air rushes in.
Initially, right, what happens, my lungs expand, right? Initially, lungs expand before the air comes in. The purpose of the lungs expanding is so I can drop my intrathoracic pressure. So the air from the atmosphere can come in, make sense? And during that time, your preload increases, right, because there's less pressure in your thorax. There's less pressure pressing against your superior and inferior vena cava, right? So the preload during that breathing time is increased, right? So preload, right, is everything that's coming in. If I give you IV, let's say I give you IV catheter here, and then I hung a bag, right, and I give you some saline, I'm increasing your preload, right? I'm giving you more fluid, so I'm going to increase your preload. Right? We're going to talk about why that's important in some certain cases, right? But any and everything that's coming in here, right, that's filling your ventricles, right, on the left side, we call that the preload.
You're increasing the preload because you're putting more fluids into
Yeah.
the tank.
Yeah, correct. There you go, right? Exactly. The afterload then becomes the resistance, right? This is the resistance we just talked about, right? It's found on the arterioles. Why it's found on the arterioles is because they have the smooth muscle.
Yeah, quick
The
question.
veins don't have as much smooth muscle. Yeah.
Is there supposed to be a valve between the pulmonary vein and the left atria?
It's a good question. Should there be a valve there? Should there be a valve here?
I'm assuming yes.
So
So
the
you
answer
create the
is
back pressure?
the answer is no. So let me get a model out. I think it will help you get further.
I think that's just all with the veins, because you have the intima media, intima ventris and shit like that.
Yeah.
And the intima media is the one that has the stretches and recoil. I think that's probably the one pushing the blood. I think so.
Before you get into that, Nick, so preload is measured in mLs, right?
Yeah.
Afterload is
Like a
measured
what?
how?
Letter reading?
And it's just so it's measured in dynes, right? In dynes, and usually you don't need to know this, right?
Okay, but it's
But
not measured in
yeah, it's like the normal value is about 1,200 dynes, right?
dynes.
How we would measure it in the hospital setting? We'd place a catheter. It's called a Swan-Ganz catheter, right? And it's gonna go through here, and it's gonna get lodged in your pulmonary artery, and then we're gonna measure all these pressures.
A quick question, Mark. He was saying about that the pulmonary vein should have a valve.
Yeah.
Doesn't that have to do with the tunica intima, media, and adventia? And the tunica media is the one that has stretch receptors and recoil to make the blood kind of push.
So the tunicas, right? Tunic means just the coat, right? And the intima media and all that, this is the layers of the vessels, right? But look, in terms of your heart, right? So I'm holding hard. This is how it sits in the chest, right? I'm gonna open all these chambers, right? So now look, this here, right? That I'm having my fingers in. This is your left atria, right? Left atria is this one here, right? And we said pulmonary vein comes to the left atria. So you see, there's 1, 2, 3, 4 inlets in here, right? In this where my fingers are. See it? 4. And 1, 2, 3, 4. All of them going into
Right.
the left the left atria. This whole thing is the left atria. So this is your pulmonary veins that are coming into your left atria. There's no valve in them. It fills passively. There's no valve from here to here. That's why when I was telling about the Swan-Ganz, right? We put a catheter here, right? And so the catheter sits in the lungs, and because there is no valve here, we see what's happening to the left heart, right? So we put a catheter here that sits in the lungs, right?
I mean, would that be a reason why CHF is so common, I guess? The backflow of it,
So CHF is not per se the commonality of it. It's not per se it's common. What happens in CHF, right? If you have, let's say, failure of the left heart, right? The left heart is not pumping, right? Based on this diagram, right? This is not contracting. Where do you suppose fluids are going to back up? To the lungs, right? But we know that fluids cannot just, sweep out from the pulmonary veins. The exchange usually occurs at the capillaries. So we see that pulmonary capillaries, right? Maybe I'll put this diagram like this, right? You have pulmonary capillaries, and as the blood backs up, right? Do you think pressure in these vessels becomes higher or lower as the blood higher? So the moment it comes to the pulmonary capillaries, where exchange can occur, because they have openings here, right? That fluid and the plasma will seep out, and that's how you get pulmonary edema. If this occurs on the right side, right, the backup goes, this is not pumping, right? So the backup is here and here. So that's why if I drew my jugular veins, right?
You forgot to record.
No, it's recording.
Oh, it's recording?
Yeah, it's recording. It's
So
good.
is pedal edema, could that be a late sign of CHF? Because usually left ventricular failure happens, and then right ventricular failure is secondary to that usually.
Yeah. So in the setting of congestive heart failure, it's usually biventricular, meaning you have both, right? Yeah. So if your left side is not pumping well, the backup is going to be in the lungs, and then the right side is going to feel it because it has a higher pressure to pump against, and then you'll have this, right? So if the right side is not working well, right? If this was your internal and external jugular veins, right? You're going to see engorgement of them, so they'll become bigger, right? Because the fluid is backing up. Same thing, right? It goes to your legs, inferior vena cava, right? You will see pedal edema developing, right? Also, you have your liver here, and if you press on the liver, we call it hepatojugular reflex, right? If you press it down and there's a lot of edema, you'll see the backup now forming on your jugular veins. So we call it hepatojugular reflex because of that.
And that's why those patients get furosemide, Lasix, to get
Yeah,
rid of
to diuresis, correct, right? So far we talked about preload, right? All the fluid that's coming in. We talked about afterload, the forces the left ventricle predominantly has to overcome in order to pump the blood forward, right? Contractility refers to the strength of the contraction of the heart, right? And since I'm already on this portion, right, all of this corresponds to the Frank Starling's law, and what Frank Starling said: the bigger the stretch, the bigger the preload that's coming in, the bigger the contraction, right? To a point, right? So the more preload you bring, the more the stretch, and the bigger the contraction. So how all this related to the flying Starling is basically the more preload you come in, maybe I'll give you IV fluids, right? Maybe give you 500 ml. A bigger stretch because of the bigger preload, bigger the contraction. And that's why we employ, right, to increase someone's blood pressure, right? Since we're talking about this, right, I'm just going to write down your formulas, right? We remember cardiac output was heart rate, right, times stroke volume.
Mm-hmm.
And then blood pressure was cardiac output times systemic vascular resistance or peripheral vascular resistance. And this cardiac output, right, if I rewrite this formula in another way, I can write it: blood pressure equals heart rate times stroke volume times SVR. I'm taking this cardiac output, the two variables, and just adding it here instead of writing cardiac output, right? So those are the formulas you want to be familiar, and what do they mean, but we'll get to that, right? So, and diastolic volume, right? So the key term here is diastolic. So the amount of blood that's in your ventricle at the end of diastole, right? Roughly speaking, it's about 140 ml, roughly speaking, right? So I'll write about 140 ml. Then we have stroke volume. Stroke volume is the amount of blood that's ejected from your heart with every beat when the heart contracts. And it's roughly about 70 ml, right? So when this squeezes, it will eject about 70 ml. On a normal healthy person, right, 70 ml goes out. So about 140 came in, 70 came out, right? What's the percentage of that? 50%, right? 140 came in, and diastolic volume, right? 70 came out, stroke volume. What's the percentage that came out? 50. Look, I give you $10, right? That's how much came in, right? Then you go, you spend 5, right? How much you got left? 5. How much did you spend?
10.
You spent $5, so you spent 50%. Make sense? So this is exactly what this is, ejection fraction. We could calculate the ejection fraction by doing stroke volume over end diastolic volume. And you could write your numbers, right? 70 over 140 ml. So if I divide, this becomes 1 over 2, which becomes 50%. Okay? So what is your ejection fraction? Is your stroke volume over end diastolic volume. That's how much we turn this basically into a percentage. Someone who maybe is like 20% or less, they're candidate for heart transplant, or they get placed on what's known as LVAD, right? Left ventricular assist device. You guys heard about that?
Yeah.
You may have a patient, you go check his pulse, there's no pulse. You check his blood pressure, you can't even get anything. You're like, what's going on, right? And then they'll say, oh yeah, I have this LVAD. They usually have a belt with their batteries on, right? LVAD is basically, it's a machine, right, that gets placed for those patients who have very low ejection fraction, maybe 20%, 15%. The left ventricle is not pumping. Maybe they had a massive heart attack, and they were in cardiogenic shock. They basically put this pump that it doesn't pump like a heart, like like relax and contract, relax and contract. It's like a slow movement of blood. It basically just pushes blood into the aorta. Slow movement of blood. So it's like a constant stream as opposed to a contraction, right? So if it's a slow movement, you're not going to feel the pulsations, right? And does anyone know how do you take blood pressure in those patients who have LVAD?
Isn't it a special machine?
Yeah, it's a special machine. So do you know what it's called?
You're only reading the map, something like that?
So you're close. You're also close. So what we do is, it's basically you take a machine, right, and we put a blood pressure cuff on them, right, and we put this machine on where the pulse will be, maybe radial pulse or the brachial pulse, right, and we hear the sound, right, when we pump up, the sound will disappear, and then we release the cuff, we start to hear these whooshing sounds, like whoosh, 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 right? And the moment you start to hear that, we write that as map. Whenever we hear it, let's say at 7, you write map of 7. That machine is called a Doppler. Doppler machine.
Yeah.
When do we use it? Sometimes in the hospital, you have a patient a lot of edema. They have a lot congestive heart failure. They have a lot of edema. I can't feel their pedal pulse. I can't because there's too much edema. And I try to palpate. I'll palpate, but it's just forming edema. So I take this Doppler, I find it, and I hear whoosh, whoosh, whoosh. I know that's the movement of blood. I take my marker, I put an X because I'm not going to spend another 10 minutes trying to find it again. So let's say on the leg, right? Let's say this someone's foot, right? I found it here. I put an X, and next time I come in with a Doppler, I know exactly where to put it and to find it. For those patients who have LVAD, they have poor ejection fraction. How we measure their blood pressure, we put a cuff on, same way. We put that Doppler, either radial pulse or the brachial artery. We pump it up. We hear nothing. Start to, right, deflate the cuff, and you hear whoosh, whoosh. The moment you hear it, you write map at whatever number you saw, 70, 80, whatever it may be. Yeah.
And Nikolai, so with these type of patients, are you going to put an EKG on them when we see pacemaker spikes?
Not necessarily. They may not have a pacemaker. You may see a normal EKG. Or, you know what's weird about those patients? If they have a dysrhythmia, they may be in VTAC, or VFib, and guess what? They're going to be talking to you. You know why?
Because their blood's still going.
Because that pump is still pushing blood through the aorta in a slow like propeller. It's pushing the blood there.
What
So-
is that called?
LVAD, left ventricular assist device. Left ventricular assist device. So they may be in VTAC or VFib, right? Even though the heart is quivering, but they don't care because the machine is still pushing the blood to the aorta. So in those settings, right, they will say, right, if the patient is not showing you hemodynamic instability, you're going to transport them to the LVAD capable facility. You may need to contact them, and talk to the doctor, see what they want to do. You want to be careful doing CPR because you may dislodge the device, right, with those patients.
You want to be careful doing CPR.
Yeah, because that device is in your aorta. It's basically pushing the blood. So if you start doing CPR, you will dislodge him. You may kill him.
Oh, so you don't do CPR.
So
You
you
don't
contact,
have to,
yeah,
'cause
you
the-
contact, what I would do is if you see an LVAD and they're having some sort of a problem, that device usually has a number and they'll be associated with the hospital. Call that number 24/7, there's someone who's going to answer the phone for you, right? And if they have a dysrhythmia, right, before you do anything, right, and they're still talking to you, right, and you see, let's say, VTAC, right, contact that telemetry or contact that hospital. They may tell you, right, to perform synchronized cardioversion or not, depending on the doctor, right? But so you don't feel weird, right? They will have a dysrhythmia, but the patient will be fine talking, no hemodynamic instability, right? And that's because of that.
Nick, so there's two formulas to calculate blood pressure?
So blood pressure, this and this is the same. All I did was, you see how cardiac output is heart rate times.
Oh, I get it, okay.
I basically took this and I
Yeah.
and that's how I do it.
Okay. And then which one's the 140 mLs again?
140 ml is the end diastolic volume.
Oh, and
And
then what's
diastolic volume. Stroke volume is the 70 ml, right? You see how I read it here? And your ejection fraction is basically, you take stroke volume divided by end diastolic volume. That will be whatever percentage, right? Normally 50, 60%, that's normal, right? Someone who is like 20% or below, they're probably candidate for heart transplant or LVAD placement, right? So we talked about that, product stalling law, we talked about, right? The bigger the stretch, the bigger the contraction. I think these are very important terms to remember. Something else that I want to talk about here, so you guys understand, right? On this top formula, right, that I wrote cardiac output. Since we have these terms, right? So we said the formula was cardiac output equals heart rate times stroke volume, right? So this here, the stroke volume, is dependent on three things. You guys remember your premature atrial contraction, PAC?
Yeah.
So it's dependent on three things. They start with PAC, right? So preload, afterload, and contractility. Right? So what I mean by that, the more preload comes in, the more stroke volume, right? If the afterload is higher, right, the bigger the squeeze here, the stroke volume will diminish. The more the contractility, the bigger the squeeze, right, the more stroke volume I can push, right? Make sense? So the stroke volume side of it is dependent on preload, afterload, and contractility. Heart rate is dependent, obviously, on your heart rate, right? And cardiac output, right, is dependent on these parameters, right? Blood pressure is dependent on cardiac output, so this part of it, and then it's dependent on systemic vascular resistance, which is the squeeze, right? This part of it is usually responsible for your diastolic blood pressure, right? This usually is going to dictate your diastolic BP. And this part here, right, for the most part, right, this will dictate your systolic. Right? And the reason why I tell you this is because when someone has a low blood pressure, we can attack it from either side. We can attack it from the systolic side, or we can attack it from the diastolic side, right? So far we talked about these terms. Any questions about these terms, right? I think I explained, right, why there's no valve here. You guys understand, right? Because the veins, they come in through the right atria. There's no valves here, as you see, right? The other important thing, and this is going to be definitely on your test, how does the actual heart get oxygen, nutrients, Is it the blood that's going through the heart through these valves?
From the coronary arteries?
From the coronary, so it's these things here. You see how they are outside?
Yeah.
This and this. Some of the coronaries I'm going to talk about, which is important for you to know, and we're going to do the 12-lead explanation for this. So coronaries, the reason why they call the coronary arteries is because heart is sitting, right, like a crown, right, in these arteries. So they call it the coronaries, right? The ones that you definitely need to know is the first, and you see how they originate from the aorta, right? So they come in from the aorta, the aortic ostia, I should say. So this valve here, you see this aortic valve? What happens is when it,
It's a 3.
so these coronary arteries, they come in from this aorta, right? This is how they come out, right? And they innervate the heart. The moment there's systole, right, these valves, leaflets open on the aortic side. So if they open, they block your coronary arteries, right? So during systole, there's very little flow to the coronary arteries. So when do they get filled?
Diastolic.
During diastole. During diastole, this valve closes, right?
Yeah.
Because it's no longer ejecting. The moment they shut, you now have access to fill the coronary arteries. So during diastolic time is when the coronary arteries fill. The ones you definitely need to be familiar with. This is the right coronary artery, right? You see how it goes from the up, it feeds the right atria, the right ventricle, and the inferior wall, the bottom portion of the heart. It also feeds the SA and the AV node. SA node we know is the normal pacemaker, right? And then goes to the AV. So think about this. Let's say you have a person who sustained a heart attack high up, right here. He has a thrombus in the right coronary artery, very high. Do you think all of this is being fed?
No.
No.
Right? So the higher up it is, the more of the myocardium is gonna take. And let's say SA node is not getting supplied, and it infarcts. What is the next one? The AV node is gonna
AV.
work, right? And what do you expect this person's heart rate to be? Is it gonna be high or low?
Lower.
Low. That's why patients in inferior wall MI who have right coronary artery involvement, they a lot of times have heart blocks or brachydysrhythmias. Right? Brachydysrhythmias. The other side of the heart is the left side, right? The left coronary. So here, you see, this is the left coronary. It subdivides into two branches. So it comes in as the left main, right? And then it goes into left anterior descending. The left anterior descending feeds the septal and the anterior wall of the left ventricle, right? And then over here, you see how it goes lateral, means to the side? You see how it goes lateral? And the lateral side is called the circumflex. The circumflex feeds the lateral wall of the heart, right? I'm gonna draw, yeah.
So any infarcts on the left side of the heart, you would pretty much see elevations on either from V to1 or V to6, right?
Yeah, I'm gonna draw it up, and
Okay.
I'm gonna explain to you where you're gonna see the elevations. What you wanna remember is the left side, if it gets a proximal, right, coronary artery, left coronary artery involvement, you take out the left ventricle, which is the most important side of the heart that pumps the blood to all the organs.
Left ventricle.
The left ventricle. You take out the left ventricle, the guy goes into massive cardiogenic shock, right? This is what they used to call a widowmaker when you take out this entire side, right? I'm not saying the right side is benign, but left side is very, very dire situation.
That side is also bigger than the right.
Correct, right? Let me see, I'm gonna go to this board. I'm gonna diagram out the 12 lead, so you guys remember. So we start the 12 lead EKGs, doesn't matter which printer or brand name you guys use, they all are uniform, they're all standard. And by the way, in the hospital when they say when someone's EKG, they're not talking about a rhythm strip. They're talking about a 12 lead EKG, right? So the top corner is going to be lead 1, right? The bottom corner, the bottom one after is going to be V2. The one after is going to be V3. Right? What is this one? AVR. AVF. This stands for augmented voltage right, augmented voltage left, augmented voltage foot, and then we get here. This is what V1, V2, V3, V4, V5, V6, right? So far everybody's with me, right? So now what I'm going to do is we get some markers, so we'll draw out the other stuff. So now I'm going to try to show you guys in this diagram the layout of the coronary arteries, right? The layout of the coronary arteries. So we're going to pretend, I'm not saying this is what it is, we're going to pretend this is your aorta, right? And I said your coronary arteries come from the aorta, right? Yes?
Yes.
All right. 2, 3 AVF. Right? Which one is this? This is your right coronary. All of this. Yes? So we see the right coronary artery is 2, 3 AVF. Then we said there is the left anterior descending, right from the left coronary artery. Actually, you know what, let me do it, let me take a better color. I will do it slightly in a different way. Do it like this. This is your LED. Yeah?
Mhm.
And then we're going to do and then it comes. All right. So hopefully it will make sense in a bit, right? So
Makes sense.
the leads 2, 3 AVF, right? 2, 3 AVF, they involve the right coronary artery. This here. Okay. This is the right coronary artery. And the right coronary artery, we just talked about, right? Innervates the right atria, right ventricle, and your AV node, SA node, right? And it also, you see how it goes down? The inferior wall, right?
Say that again, I'm sorry.
Yeah, so your right coronary artery, as it comes out, it will feed the right the right atria, the right ventricle, SA node, AV node, and the inferior wall, right? You see the inferior wall? Inferior means the bottom wall, right? So when we look at the CKG and we say, okay, we need elevations in 2 or more contiguous leads, right? 2 or more contiguous leads. Contiguous leads, they look at the same part of the heart. It's like my wrist is contiguous with my forearm. My wrist is not contiguous with my elbow. You have this forearm before it goes to the elbow. So it means it's looking at the same part, right? So The right coronary artery looks at the right side of the heart and the inferior wall. So if you have elevations in 2, 3, or AVF, right, which is 1 millimeter or above, right, we say there is involvement of right coronary artery. Most likely there is involvement of the inferior wall, right, of the heart. Inferior wall is the bottom wall.
So it has to be like 2 out of those 3
Yeah.
to confirm.
Two out of this 3, yeah. 2 out of this 3, yeah. So these are contiguous, 2, 3 AVF, they fed by the right coronary, and they signify, right, the
But
part.
You're
in
not
the
counting
inferior wall.
AVR.
AVR, I'm not counting. There is a special condition where this may be elevated. I'll show you. But right now, this is excluded from this EKG. So everything else we're counting except AVR for now. Right. So any questions about 2, 3 AVF? Right. Feeds the inferior wall, right side, right coronary. Next one we're gonna go to is, we said the left coronary artery. This is the left coronary artery. Right. This is the left coronary, and you see how it goes down here and then goes to the side. The one that goes down here, this is called the left anterior descending. Left anterior descending, right? And you see how I drew it V1, V2, V3, and part of V4? You see how it goes through there? So V1, V2, V3, V4. Usually when it's only V1 and V2, we say it's involving the septal wall. This is V1, septal, V2 septal, V3, this is going to be anterior.
Left anterior descent.
So any infarcts, you will see elevations in those leads.
Yeah, yeah. So if you see, depending on, is it higher up or is it lower down? So let's say it's higher up, you may see the entire side of it being elevated, even involve the lateral side, right? If it's lower down, right, you may see only maybe the septal or the anterior side, depending on where the lesion is or where the thrombus is, right? And then this one that goes to the side, you see how it starts here and goes to the side, to the lateral side?
Circumflex.
Yeah, this is the circumflex, and
It comes from the left anterior descending.
this was inferior. The lateral, as the name suggests, right, feeds the lateral heart. Right, see how it turns around? Right? And that's why when we were in class, right, remember when we do a 12 lead EKG, we put the limb leads on the limbs. Why we put them on the limbs is because they said these are augmented voltage. What do you think augmented means to you? What is augmented?
To look close.
Amplify, increase,
Amplify,
right?
yeah.
So think about this, if I take the limb leads and I put them on your torso, I put it on your chest and your abdomen, what do you think is going to happen?
Seeing a closer look.
And you're not seeing a closer look. If I told you this stands for augmented voltage,
Doesn't that mean uniform, like they're uniform?
not per se the uniform, what happens is this, they will over amplify, they will over augment. And if they will over augment, you may have false positive, meaning they may show you elevations where there isn't any. That's why these go on the limbs. So anytime you do a 12 lead EKG, limb leads must go below the inguinal ligament, so below this portion and below your shoulder, right? If you do like a regular 3 lead, it doesn't matter where you place it, right? It doesn't matter where you place it. But for a 12 lead, right, you need to place them on the limbs, right? Now, so these goes on the limbs, these V1 through V6, they go on your chest, right? We call them the Precorial Leads. Now, look at how my heart sits, right? So we put V1, V2, right? And then we put V3, V4, V5, V6 on the side like this, right? Make sense? But is there anything that's looking directly at the right side and then the back of the heart? Nothing, right? So for us to get the right side of the heart and the back of the heart, we gotta do what? A 15 lead EKG. How do we do 15 lead EKG? We just take off V4, we place it on V4 right. So now I can look. You see how it's pointing now to the side? And then if I want to get the back wall, I put my leads on the back, right? I put it on the back. So I put them on the back, that'd be V8, V9, and it's gonna look at the posterior wall of the heart. When do we need to do a 15 lead EKG? Anytime you have elevations in 2, 3 AVF, or you have depressions in these V1, V2 in the anterior leads, because these are reciprocal changes. Why are they reciprocal changes? If you have elevations in the inferior wall, where do you think you see the opposite? The opposite side is the anterior wall, right? That's why you'll see reciprocal changes here. So if I have elevations here and I have depressions here, I'm probably going to do a 15 Lead Ekg, right? If the lesion is high up, like the lesion is higher up here, right, as we said, it can take out both the LAD and the circumflex. It takes out both of these, right? Very bad for the patient because the entire left ventricle is infarcted, right? And you see how much bigger this is as opposed to the right side, right? It's very muscular. It supplies blood to the entire body, right? I take this out, this person is going to go into massive cardiogenic shock, right? If they go into massive cardiogenic shock, right, besides, right, you helping them, maybe you need to give them 250 fluid, start a pressor. In the hospital, they may be placed on the balloon pump, right? If they survive, right, and they get discharged, they have a long time to rehab because this supplies a lot of organs in your body, right? So it's very important that we get them urgently fast to the cath lab capable hospital. That's why you guys are seeing you do a quick EKG to say, right, is the elevation or not? Hold telemetry, transmit, and take him to the cath lab capable facility, right? Per the AHA, I'll just write down the numbers for you so you know in terms of why they're making you guys hurry up and do this very quickly. The AHA has changed some criteria. So what they said is following. Before, there was a term known as door to needle time or door to balloon time. So door to needle means a person was going to get TPA, right, to lyse the clot. Or door to balloon time is when they go to the cath lab, they get angioplasty. They basically get a catheter placed, the balloon inflates to open that vessel, and they put a stent. Before they used door to balloon or door to needle time. What that means is that when you go through the door, now the term has changed. It's first medical contact to balloon or first medical contact to needle time. Who makes first medical contact?
We do.
You do, right? So this is what they said. They said the hospital has, right, less than or equal to 90 minutes to basically give them TPA, right? And if they do not have no cath lab. If they have a cath lab. If they don't have a cath lab, they give them 120 minutes because they want to account for transport. So let me just repeat it. I think I wrote it. So you guys understand. So the moment you make contact with a person and they said we have chest pain, it's less than 12 hours, you determine, right, it meets the criteria, you did a 12 Lead Ekg, has a STEMI, right, 2-3 contiguous leads. They want to take this person to the PCI, stands for Percutaneous Coronary Intervention, basically a cath lab, within 90 minutes, right? Or they got to give them TPA, right, meaning a clot busting drug, if they can do it. The other place, if, let's say you take them to a hospital that doesn't have a cath lab, right, they give them a little more time because to account for the transport to the cath lab facility, they want to do it within 2 hours. If they cannot do it within 2 hours, they got to give them TPA, right, TPA. What's the problem with TPA?
It could cause bleeding elsewhere.
It could cause bleeding elsewhere. There's also contraindications, right? If you had recent stroke, you had severe bleeding, right? Also, there may be complications associated with it, right? When you give this medication, because it will lyse clots not just in the heart, it will lyse clots everywhere in the body, right? So PCI, this is a safer procedure, right? Because they directly go to the coronary arteries. They could inject dye, they'll see which one is closed and open up the specific coronary artery, right? And this is why they have these time frames, right? And this is why when you're called for this type of call, you want to do EKG rapidly, interpret the EKG and transmit it to the telemetry so they can call the cath lab and say, okay, is the doctor there? All right, we're going to transport the patient there, okay? So 90 minutes for the PCI or 120 minutes if there's no cath lab there. Or then they're giving them TPA. Right? TPA stands for tissue plasminogen activator. So it will activate the plasminogen factor, will lyse all the clots, right? Not just in the heart, everywhere, right? And in terms of, right, so we talked about the EKG, we talked about a little bit about cath lab, right, the definitive treatment. What about the treatment on your end? Like, what are you guys are going to do? You have a patient having chest pain. Let's say he has elevations in, let's say he has a massive MI in the anterior leads, V1, V2, V3, V4. What are you going to give him?
I feel like there's not really much we can do. We can just give oxygen, give aspirin, nitro, or morphine, depending on their vitals. I trust them to make a notification, and that's it.
So let's look at your let's quickly look at the treatment, right? In terms of we have to establish priority, like what's important, what's not important, right? So we're gonna go here, which is your Remake Protocol, right?
And you want to get vitals and just treat whatever isn't right. Low BP, pressures, low 2, up,
Pretty much.
shit like that.
That's what I can think of. Shit like that, you know.
Shit like that.
All right, so PGT, right? So here this is both they call it acute coronary syndrome, right? Suspected myocardial infarction. They have both BLS and ALS protocols
Is
here.
that the new one?
This is the new one, right? So the first, if you see, right, we are going to go, they have CFRs here, and then they have EMTs, right? So we are going to administer chewable 324 milligrams aspirin, right? See, it's up here. Let me make sure. Yeah, this is good. So chewable aspirin, 324 milligrams PO, right? Why is aspirin listed higher up in the protocol?
Then what?
Proven to help,
Yeah, how?
by preventing additional clotting.
Right, so it does not allow more clots to form. It's a thromboxane A2 inhibitor, and it's shown about reduction in mortality, reduction of death by 23% if given early. So if guy's having a true MI STEMI, right, you give him this aspirin and he's not allergic to it, you reduce his chance of dying by 23%. Right? So this is the number one drug you give. You definitely give oxygen if their saturation is less than what?
95.
Less than 90%, right? Less than 90% per the new AHA guidelines, right?
So it's 90%?
90%, right? Per the AHA guidelines, less than 90%, you give them oxygen. You can give them nasal cannula, you give them another breather mask, right? And then, right, then we move to the EMT protocols. They say, if available, assist patients with their prescribed nitroglycerin, right? So what is nitroglycerin for? What does it do? Vasodilate. What does it vasodilate?
It dilates the coronary arteries, so there's there's more space for blood to flow,
Okay.
and it relieves pain.
Release pain. Okay.
Doesn't it also work on peripheral vessels as well to
Yeah.
decrease preload?
Decrease preload, right? So let me go through this diagram so you guys can see, right? So what I mean. So in terms of what you said, you're saying everything correctly, right? But just to correct something, right? So nitroglycerin is a potent nitric oxide donor. What a nitric oxide does, it does dilation both of your venous side and your arterial side, right? Now, if your coronary arteries are healthy, right? Yeah, it will have some coronary artery dilation. But if you are talking about that patient who is 70 years old, he has atherosclerosis, right? Plaque, and arteriosclerosis, hardening of the arterioles. They harden, and there's a lot of plaque, right? And there's thrombus that disrupting, right, that vessel wall. Nitroglycerin is not going to cause so much arterial dilation. It won't, because that plaque and that arteriosclerosis is there, has been there for years, right? So what you predominantly see in those patients is going to reduce this preload on both sides. But how does this preload help me reduce the pain?
It's decreasing oxygen.
It does what?
Decreasing oxygen.
You're making better the contractions of the heart. The heart is not contracting as faster anymore.
The heart's still contracting as fast as it was.
Putting less pressure. No.
Explain it more for me.
Is decreasing the afterload so it doesn't have to pump against.
So
as
yeah,
part of
you will
resistance.
you will decrease that afterload, right? You will decrease that afterload, and more importantly, we just said it reduces the preload. Make sense? So look, I reduced the preload. You know the preload is all the blood that was coming here, right? Now it's less. that blood also has a force that's pushing against that wall of the heart. Make sense? So the more it fills, it pushes against the wall harder. And let's say there's a vessel, we just said the vessel was damaged, let's say here, right? There's a thrombus here. So the blood is pushing against this vessel, there's a lot of blood. I lowered the blood. There's less pressure of the blood pushing.
Releases the pressure.
Yeah,
on
it releases the pressure. So by reducing the preload, I reduce my intraventricular pressures. There's less blood in here, less pressure pushing against this thrombosed vessel, right? So maybe more blood is now moving through the heart, right? More of it circulating. So the predominantly how you're helping these patients relieve that pain is reduce the preload, less of it is pressing against that vessel that's thrombosed, right? And hopefully more blood is flowing through it, right? So that's the major stuff that the nitrates do for you. What you want to be careful about nitrates, you want to make sure, right, the blood pressure is maintained, right? And the person has not taken any erectile dysfunction medications. Why? Because they work together, right, as nitric oxide donors, and they could compound and cause profound vasodilation. The other thing I will tell you is whenever you give nitroglycerin, make sure the person is not sitting up, they're lying down, right? And you want to have IV access established. Why? Because in case they have profound, right, vasodilation and they drop their blood pressure, right, you could lay them down flat and open IV fluids to get their blood pressure up. Make sense? Right, so let me go back to the drug.
So you said when we treat the patients, lay them flat?
What I'm saying is when you give them nitroglycerin, you want to have your patient to be on the stretcher, right? You don't want them sitting up on the bench or somewhere like that. Why? Because I give you nitroglycerin, and let's say you have precipitous drop in your blood pressure. Let's say your blood pressure was, 114 over 90. I give you nitro, and all of a sudden your blood pressure drops to 80. Quick drop. And the guy may lose consciousness, may fall. And at that time, what I would do is I would lay him flat and open my IV fluids. Hopefully you have IV access established. IV fluids will come in and you'll get the person back. If you did not have IV access established and this happens, it will be very hard to find a vein, right? Because their blood pressure is low. And it's very, very hard to find veins on someone whose blood pressure is very low, right? So for EMTs, they say 120, this is assisting. But for, right,
You can still find it, it's online.
Yeah.
for here on the paramedic side, we're not going to be assisting with the prescription. We have our own nitroglycerin that we carry, right? The dose is what?
0.4.
0.4 milligrams, right? Make sure you remember that. Sublingual, right? Every 5 minutes as needed. And they say you want to make sure the blood pressure is, right, greater than 120. In the hospital setting, they give this medicine usually to a certain blood pressure. They will say, like, give this every 5 minutes to maintain X blood pressure, right? How does it lower chest pain? I just explained, right? Lowers intraventricular pressure, right? So, and you see it says here, you want to transport them to this STEMI capable facility. By the way, this was a funny story. I used to volunteer for an agency, and we would call in the morning RCC and we say, what's the diversions, right? Where the diversions, they say, this hospital's diversion, this hospital, and they'll say, this hospital is on STEMI diversion, right? And if you were an EMT and you didn't know what that meant, right? Didn't know what the STEMI, you're like, well, okay, whatever, right? So what this stands for, it stands for ST segment elevation myocardial infarction, right? Percutaneous coronary intervention. So this is a place where they could place a stent, right, for you, or open a balloon, right? So this is where you want to take them. You want to call telemetry to do this. Now let's go down to the list of your medical control options, right? So here we have, right? So the transport decision is there. You have any unstable dysrhythmia prior to acquisition of a tolling. So what this basically saying is, let's say you have a person who has, let's say, ventricular tachycardia, right? Or ventricular fibrillation. You want to treat them before initiating tolling. That makes sense. Why? Because let's say I have an MI, I have an ischemic heart, right? And now the ventricle is becoming irritable. And all of a sudden, right, the irritable ventricle may have the ectopic foci, and they start beating on their own rate. And if that rate is above the SA node, the heart is going to pick up the fastest cell that it has. So maybe it's the ventricles that it picks up. So you have fast ventricular rapid rate. We call that VTAC. right? And that we need to treat before we do a total, right? Once you treat it, you correct it, right? Let's say I give him medication or I cardiovert him, I correct it, then I do what? I do a total, because I want to see what's the underlying rhythm after I converted that, right? You want to give aspirin that's not entirely coated. Why? Because we want a sublingual route. We want them to chew it because we want to stop platelets from aggregating, right? You don't want it to be entirely coated. You want to make sure they don't have allergies to this medicine. We just talked about, right? You don't want to give nitro to anyone who has erectile dysfunction medications like Levitra, Cialis, right? Viagra. Females can be taking these medicines for pulmonary hypertension. So ask what medicines you take, right? And you see, right, if available, you want to give fentanyl. Why is it preferred? Fentanyl has a better hemodynamic profile, less chance of lowering the blood pressure, right? The way you want to remember this, and I want to ingrain this in your mind, right? First, you want to correct any life-threatening problems. Secondary, you correct any comfort care. If you reverse it, meaning you do comfort care first, and then you're going to address their life-threatening situations. This is how we kill people. For example, you go to a call, right? Same guy, right? Cardiogenic shock, but he has VTAC. You put him on the monitor, VTAC. Blood pressure, 70/40. You're like, oh man, we got a cardiorrhythm, but we're going to sedate him first, right? We're going to give him some diazepam.
You lose some time, man.
Right? It's not about losing time. What does diazepam do? Diazepam is going to vasodilate you, right? You're going to bottom out his blood pressure. Before you cardiorrhythm, you're going to kill him, right? So a major contraindications for your benzodiazepines is hypotension, right? So you gave your comfort care first, right? And your comfort care has killed the person. So in terms of your priority, save the guy first, comfort care second. I'm not saying not to do comfort care, but I'm saying should not be the top of your list, right? And in that setting, right, what is a better choice of medication for sedation for cardioversion? And you want to remember from your protocols?
You said bad?
Better.
Oh, better.
That's better in terms of hemodynamic stability.
Tamponade?
Etomidate, right? 0.15 milligrams per kilogram, right? Better than the diazepam or your benzos, right? So, right. So this is for that. Yes.
Since I would still make up.
Yeah, just hang out, and if anyone else comes in, otherwise you could clean up your stuff. Yeah. All right. So this is your major treatments, right? And then just to show you guys the AHA side of it.
Did you find it?
No, I didn't. I think it's medical control options for suspected MIS.
It's up. Very nice. Just go to Google. Just put it
We go by the Remake, right?
Correct. You guys go by the Remake, but you're also going to be doing what? You're going to be doing ACLS, right? Shortly. So I wanna show you. It's a little small. Let me make it bigger.
protocols.
Wait, slow down.
All right. So this just to be clear. This is AHA, right? So this is oxygen, right? Remember I was telling you oxygen. And what does it say? Acute coronary syndromes, right? Administered, right? Outgoing ischemia, less than 90%.
¿Salió?
For patients who have suspected stroke, right, we're going to give them if they're less than or equal to 94. But for ACS, less than 90. Why? Because they determined that high oxygen for those who have good saturations was causing more harm because of free radical formation. So less than 90%, you put them on pulse ox, it reads 88, right? Put them on nasal cannula. They're reading 96%, right? I probably will not give them oxygen.
If you come on a scene, BLS is there, they administered the patient's 3 doses of nitro.
Yeah.
I need to get a line, I can't. Would you do IO?
And the patient is very hypotensive, and you cannot.
Yeah, like you need to get in.
Yeah.
Okay.
The other
So
one
that's the next.
is doing the external
you can-
jugular. External
okay.
jugular, yeah. Because if you don't correct the hypotension, right, there's basically no flow to the brain and to your coronary arteries. You will basically kill the person, right? And since we're on the topic of the blood pressure, right, the other formula that I did not write, but we definitely want to keep in mind, right? Let me just do it now. which is a good testing one too, right? See, this is getting it. Right, so the other formula that you want to be familiar is your mean arterial pressure, right? And the formula for that is 2 times diastolic blood pressure plus systolic blood pressure divided by 3. The other way to do the same formula is just a different way. So MAP is equals 1/3 of your pulse pressure plus your diastolic blood pressure. They're all going to give you the same answer. We're going to do it shortly. Pulse pressure, what it means is your systolic blood pressure minus your diastolic blood pressure. All of these formulas mean the exact same thing. You could use whichever one you want. You definitely need to remember the formulas, right? So let's why they tell you, okay, you want to have systolic greater than 90, right? Let's do a blood pressure 90 over 60. Let's just do it. All right. You want to use your calculators on your phone? You have your calculator up? All right. So do this. So 2 times 60 is 120. 120 plus 90. 210 divided by 3. 70, right? 70, good. So, and they say you want to have a map of greater or equal to 65, right? And you need 65 to get blood flow to your heart and to your brain, right? And now we see, right, at 90 over 60, your map was 70, right? Which right here, map was 70 millimeters mercury. So now we are above 65. That's why they tell you you want to have systolic of 90 to get a map of equal or greater than 65. Make sense? The moment it starts to go below the 90, your map starts to drop. Your map starts to decline, right? And these formulas are important for you to know to calculate your mean arterial pressure. To give you a note how maybe this will make it easier for you guys to understand. If I pretend your blood pressure right now is 120 over 8, right? Let's just normally your systolic phase of the contraction, right? Systole is about 0.3 seconds. Right? Your diastolic phase, relaxation, do you think it's shorter or longer? Longer, right? It's about 0.5 seconds. I'm talking about like normal person who doesn't have any problems. Right? Altogether, this is 0.8 seconds, right? 0.8 seconds. This was systole, this was diastole. Right? So let me put it like this. So we take your blood pressure, right? Here would be 120, this would be over from 0 to 3 seconds. And then from here to here, this would be 0.8 seconds. And this would be 80. This is systolic, this is diastolic. If you combine this two, we have 0.8 seconds, right? What is 60 seconds divided by 0.8? 60 divided by 0.8.
54.
60 divided by 0.8. It's like 75.
75.
Yeah. So that means when my heart rate is 75, right? When my heart rate is 75, it takes 0.3 seconds to have the systolic phase. It takes 0.5 seconds to have the diastolic phase during relaxation, right? Now I want to take an average, right? I want to take an average. So if I take an average, right, I cannot say the entire time my average is 120, right? Because 120 is only over 0.3 seconds, right? So when we do the formula, right, we see that the map for this number, I know because I've done it so many times, it will be 93 millimeters of mercury.
It's giving a more accurate average.
Right? So this will be 93. Right? So that's why we do the formula, because why do we have divided by 3? Is because we cannot say 120 is the entire time. We cannot say 80 is the entire time. Right? We have to account for this systolic and diastolic phase. So the 93 is if you took this numbers 120 over 80, you plugged it into the formula, you'll get 93. And in the hospital, right, the way we titrate our pressors, like levofed, norepi, right, dopamine, is based on the MAP, not based on the systolic and diastolic. So we put a patient on the pressor, I want to make sure my MAP is 65. How do I know? I look at my monitor, and we have the arterial line that tells me how much the pressure is on the arterial side. For you, you're going to use your regular monitor. There's going to be, when you do a blood pressure, it's going to give you three numbers. It's going to say like 120 over 80, and on the box, like on the side of it, it will say like 93 or 92. That's your MAP. You could use that as your mean arterial pressure, right?
But I heard they're focusing more on the map now, right?
Yeah, MAP is.
So why is it like getting more important now?
Why it's more important is because it's taking the average pressure, right, of both the systolic and diastolic phase, right, together. And why is this more important is because what if you have a person who starts to have differences in their blood pressure based on their systemic vascular resistance, right, their afterload. So what do I mean by that? Imagine that you have the following patient. He had a massive heart attack, right? And his heart is not pumping, right? Blood pressure systolic drops. But what the body wants to do, wants to maintain the blood pressure. So he's going to do what? He's going to send epinephrine to vasoconstrict the arteries, right? He's going to send epinephrine to hopefully heart beats faster because it's your fight or flight response, right? When you're in shock. So that vasoconstriction, even though your systolic maybe 90 in the initial phase when you're compensating, the diastolic can rise. It will become like 82, 84 initially. The diastolic rises. Why is it rising? Because you have vasoconstriction, right? And we said this is the systemic vascular resistance responsible for the diastolic blood pressure. So the MAP will be a better indicator because it takes that into account. If we just look at the systolic, we basically ignore it, right? And there'll be conditions where you have a narrowing pulse pressure, we have a widening pulse pressure. Right? Especially when you learn in neuro, right? In neuro chapters, where you have systolic rising, right? So we have widening pulse pressure. Or we have cardiac tamponade, where around the heart, right, we have a sac, right? There's a sac around the heart. And that sac, let's say, is filled up with blood or some other fluid, and the heart cannot fill because the sac is not allowing it to expand. Right? So systolic drops because it's not getting the preload, and the diastolic rises because the body is saying, oh my God, blood pressure is low, I gotta vasoconstrict. Right? Vasoconstrict, so you have a narrowing pulse pressure because of the diastolic vasoconstriction. That's why we tell you, right, get both diastolic and systolic and trend it. Now you can also know about the mean arterial pressure. So this gives us a better overview of what's going on. Because this takes both diastolic, systolic, and it takes the time frames also of the cardiac cycle. So this formula you definitely need to know. This is the overview of the stuff of the EKG. Trying to think. Oh, the pharmacology I started. Let me just finish this up. Sure, grab the screen. We'll do finish up with the pharmacology. All right, so oxygen we talked about, right? 90% AHA, right? And then let's go to I want to show you some stuff so you guys remember. So nitroglycerin, right? And I want to ask you, nitroglycerin. Right, we said we're going to give 0.4 milligrams as your protocol say, but you see contraindication means when you don't want to give it, right? So we know hypotension, right, that we already talked about, right? Here they say blood pressure less than 90 or equal or greater than 30 below their baseline. For you, you're going to use your Remake Protocols. But my question is, you see how it says severe bradycardia less than 50? Or tachycardia greater than 100 is a contraindication. Why?
Because it could be a compensatory mechanism that you're taking away.
Excellent. Explain more.
So,
They could have. You're supposed to treat the underlying, like you're supposed to treat the tachycardia. Like their heart rate could be 150, but it's not an SVT. It could be like a sepsis or something like that. So there could be a reason why their heart rate is that fast that their body's compensating for, and you're just giving them.
Like they could be in shock.
So,
Right.
so essentially, it's not because something else is compensating for him. They could still have ACS, right?
Yeah.
But they could have a tachycardia associated. So think about this, right? When you have a tachycardia, fast heart rate, what is actually decreasing? What's decreasing is your diastolic time. See, the diastolic time was 0.8 seconds. If your heart rate is like 140, the diastolic phase shrinks. Maybe it's the same now as your systolic. And what happens during diastolic time is when your heart fills, right? I decrease my diastolic time. I have no fill. I give you nitroglycerin. Nitroglycerin does what? Vasodilation, right? You're already not pumping enough. I drop your preload, right? What is coming out? Nothing, right? Same thing, you have severe bradycardia. Your heart rate is 40. You're in 3rd-degree heart block, right? And you also have ST segment elevation, right? Severe bradycardia. Again, I give you this medication, vasodilate you. You have no preload, right? You can't compensate. Next thing we go to the RV infarction. This is for right ventricular infarction. Why is that a problem? RV is here, right? The right ventricle. Right? Why is this a problem? Right ventricle, infarction, right? Not pumping well. Nitroglycerin does vasodilation. I give you vasodilation, I make this tank bigger. More or less blood coming in? Less. Now the heart is weak. Right? What's going to happen? Less preload
That's oxygen.
and less cardiac output. Right? We have the formula. Right? Cardiac output drops. So RV infarction is another contraindication, right? That's why we tell you to do, if you have inferior wall MI, we tell you to do what? The right side EKG to rule out right ventricular involvement, right? Right? This is basically your erectile dysfunction medicine, right? By the way, you notice how this stuff was not listed in your Remake Protocols. Whose responsibility is to know these contraindications? Yours, right? Why?
Because we're treating.
Yeah, because if you give this medicine when there was a clear-cut contraindication and the person suffers, right, let's say death, right, which is the ultimate side effect, right, you're responsible, right, because you gave this drug not assessing for their contraindications or not knowing them. That's why very important to look at your drugs and look at it. So this is for nitroglycerin, and the other one that I want to show you over here.
I would blame the fire department.
You will blame the fire department. Yep.
You're the medic now. You can't blame the fire department no more.
We're not
You're
putting,
gonna blame Finny medics even though you're the medic.
no, we're not putting that in the protocols.
You're going to be it.
Oh,
We'll be waiting for you, Angelo.
Yeah.
We'll be waiting for you.
Relájate, relájate.
I'm sure you go to Staten Island.
Yeah.
Stay there.
So this one is amiodarone, right? I just want to show you, but it's I'll show you where I got this from, so you could download it if you like. So amiodarone, right? When do we give this medicine?
For
Dysrhythmias, right? Especially, right, wide complex tachyarrhythmias, like you may have a patient who had a heart attack, the ventricles are becoming irritable, he's now in ventricular tachycardia, he still has a pulse, right? But we give a amiodarone drip if the dysrhythmia is still considered stable, right? Patient is alert oriented, right? Systolic is not less than 90, right? So I wanna show you, right? So this medicine is used for treating tachydysrhythmias. You'll see it has a mixed effect. It has a sodium blocking effects, potassium, calcium, right? But indications, right? They tell you use for VF, ventricular fibrillations, or pulseless ventricular tachycardia, right? Or hemodynamically unstable ventricular tachycardia, and right. I want to show you the precautions. Right, precautions. So you started this drug. It says rapid infusion will lead to hypotension. That means that you may have someone who is in VTAC. You put him on this drug, right? And his blood pressure was, let's say, normal or normal for him. You started this drug. In a minute, his blood pressure can go from 110/80 to 60/40. Right. So what is the first action that you need to do?
Stop it.
Stop it, right? So good. And the other thing, when I start this drug, I put my monitor at the fastest time I can get the blood pressure. So let's say every 2 minutes interval, or one in the hospital every minute or whatever. So I put this at the fastest interval and I let it cycle. And if the patient complains saying, how come it's squeezing my arm, I'll explain, we need this because this medicine may drop your blood pressure. So if I see a precipitous drop, I will, right, discontinue this medicine, right? This other thing is, if they have other drugs that prolong the QT interval, you will need to know the 12 if you don't have it. The other stuff that's not listed here is this drug needs to be given with the filter. And the filter is needed because there's crystals and it can cause basically phlebitis in the person veins when you're infusing it. You also want to make sure, right, you're using a large gauge catheter when you're infusing it. And the other thing is, don't shake it vigorously. You shake it vigorously, it's going to foam up. It's going to look like a foam thing, and very hard to infuse it. So don't shake it vigorously. You put it in the 100 bag, gentle, right, gentle roll, over 10 minutes. You want to have a filter, but a lot of places don't carry. I don't know why, but this is very big, right? So blood pressure, and I've seen patients who medics started this drip and they went into arrest, not because they went into arrest. They went into arrest. They're like, oh, we had a pulse VTAC and now it's pulseless VTAC. Do you know what happened? Blood pressure drop. Blood pressure drop, right? If you have a person who is NO times 3, right, and you start this drug, right, you want to get the blood pressure very quickly. If the blood pressure starts to drop, you stop the drug. What are you going to do? Call telemetry. Say, listen, person becoming unstable, right, probably needs a cardioversion, right? But if the guy goes from, right, pulses and talking to you, all of a sudden he's out after starting this drug, first step, stop the drug. Stop the drug. Don't start running your cardiac arrest. Oh, we went into pulseless VTAC, start CPR. Stop your drug, right? All right. Any questions?
So you stop the drug, and then what do you do?
Reassess your patient and see where you are. Maybe you stop the drug and blood pressure rebounds. I'll probably start running IV fluids, lying flat, right? And see if I still have VT on my monitor. I have VT on my monitor and the pulse is still there. Probably the drug precipitated drop in the blood pressure. I'll call medical control and probably going to go with synchronized cardioversion. Yeah.
So we have to know these protocols in addition to our Remake Protocol.
Yeah. So this is ACLS, right? Medications. I advise you. I'll show you where I got them, so you could download them if you like. My advice to you is, every single drug that you're giving, you need to know your indications and contraindications.
It's standing orders to synchronize cardiovascular.
Yeah.
For VTAC.
With unstable, right? Unstable.
Yeah,
VTAC.
unstable.
But stable, you're gonna do what?
Administer amiodarone.
Right. Does it say anywhere about these contraindications?
Um,
Not in the protocol.